Hello, my name is Natica Farrell, and this summer I worked at the New York City Department of Health and Mental Hygiene and primarily contributed to recruitment for a research project called Power Up that aimed to evaluate the effectiveness of a national diabetes prevention program that is specifically targeted toward Black and Brown men. For my presentation, I decided to combine my internship's goal of targeted diabetes prevention with my personal interest in reproductive and maternal health. And so therefore today I will be discussing racial and ethnic differences in the prevalence of gestational diabetes and the implications of those differences for gestational diabetes prevention and intervention methods. Before I begin, however, I would like to provide a quick disclaimer about the language that I'll be using throughout my presentation. Although people of different genders, not only women, are able to become pregnant and give birth, the majority of the research on gestational diabetes does use binary language. And for the purpose of staying true to the research that I analyzed and representing it accurately, I decided to mirror the language that was used throughout the literature during my presentation. However, I do think that moving forward, it is important for health fields to incorporate more inclusive language into research. So the first thing that I would like to do is provide a bit of background on the impact of gestational diabetes. Gestational diabetes mellitus, or GDM, can be defined as any degree of glucose intolerance with onset or first recognition during pregnancy, and it affects about 7% of all pregnancies in the United States. GDM can have significant impacts on a person's health both during and after pregnancy. For example, gestational diabetes has been associated with intrauterine fetal death, fetal macrosomia, maternal hypertensive disorders, and the need for cesarean section. Even after delivery, GDM is associated with a higher risk of type 2 diabetes for both mothers and offspring, and a higher risk of obesity in offspring. So the overall objective of my research was to explore the differences in prevalence of GDM across racial and ethnic groups, and to examine the lasting impacts of GDM on the health of non-white populations. Additionally, knowing that there are differing impacts of GDM, I wanted to consider the opportunity for culturally targeted intervention and prevention methods to attempt to address some of the disparities that I found. From my research, I found that in the United States, gestational diabetes is more prevalent among non-white populations than white ones. For example, one study of more than 28,000 women found that while the prevalence of GDM in white women is 3.8%, the prevalence was 4%, 7.4%, and 5.6% in Black, Asian, and Hispanic women, respectively. Because there are risks associated with GDM, this higher prevalence puts non-white populations at higher risk of complications both during and after pregnancy. For example, to talk a little bit more about the long-term associations of gestational diabetes, in my research, I found that women who have had gestational diabetes have at least a 7-fold increased risk of developing type 2 diabetes in the future compared to those who had a normal glycemic pregnancy. In addition to future risks for the people that experience gestational diabetes, GDM might also pose risks for the offspring. For example, intrauterine exposure to maternal diabetes has been shown to increase the risk for obesity and altered glucose metabolism in an offspring. After finding that non-white populations experience gestational diabetes at higher rates, and considering the influence that this might have on the health of non-white populations both in the short and long term, I aim to explore which factors might be contributing to the differing impact of GDM on non-white populations. In my research, I found that the higher prevalence of GDM is likely a product of multiple social and biological factors. For example, biological factors that might contribute to the higher prevalence include genetic predisposition, maternal age, obesity, and a family history of diabetes. My research showed that social factors that might be contributing include cultural differences around food, the process of adjustment that immigrants must make when they move to America, mental health, lack of social support, and cultural expectations about the role of women. In general, I found that the causes of racial and ethnic disparities in gestational diabetes prevalence are likely a complex combination of social and biological factors, and more research is needed to examine some of those causes more in depth. In the meantime, recognition of the differences in GDM prevalence across groups is necessary for the development of more appropriate prevention and intervention strategies. Although there are very few culturally appropriate intervention models specifically tailored to gestational diabetes, there is evidence that culturally appropriate measures are effective in generalized type 2 diabetes prevention. In my research, I found that interventions that include ethnic languages, sensitivity to religious beliefs, gender sensitivity, community health workers, and the promoting of culturally acceptable and financially affordable food choices using local ingredients is associated with improved HbA1c levels. Another study further examined the impact of culturally appropriate intervention and determined that not only are the interventions effective, but that culturally appropriate health education was actually more effective than usual health education in improving HbA1c and knowledge. Because there is evidence of success of culturally specific intervention for type 2 diabetes, the existing research can be used to inform the creation of intervention that's specifically targeted toward populations that are at higher risk of gestational diabetes. Cultural differences can influence the impact that GDM has on communities, and these differences must be addressed in public health efforts. So one key takeaway from my research was the impact of the cycle of gestational diabetes on the long-term health of non-white populations. In the figure on the left, I aim to visualize the way that GDM can increase the risk of developing type 2 diabetes, which can lead to GDM in future populations. Because gestational diabetes puts both mothers and children at higher risk of developing type 2 diabetes later in life, reducing the prevalence and impact of GDM in non-white populations could be an important step towards reducing the cycle of health disparities in the United States. Moving forward, more research needs to be done to better our understanding of the impact of gestational diabetes, factors contributing to the differences in the prevalences, the effectiveness of intervention and prevention methods, and potential structural barriers that might be furthering the health disparities that I provided. Overall, gestational diabetes is a condition that is disproportionately impacting the health of non-white populations in the United States, and addressing that disparity is an important step toward improving the health of all Americans. Finally, I would just like to thank the SPHSP coordinators and TAs for all of their time and dedication to the program, as well as the students who really were extremely supportive to each other throughout this summer. I'd also like to thank Columbia University and the CDC for organizing this program and allowing this opportunity to exist. And then lastly, I would like to thank my mentor, Jennifer De Leon, at the New York City Department of Health and Mental Hygiene. Thank you so much.